It's a big fun to be member of Dental XP family. It's pleasure and it is honor. It's not that easy to get here. Let me tell you a story. It is the first case that I posted on Dental XP forum, and here's the comment.
Dentists are doers, and we get paid for doing some treatment, but sometimes retrospective thinking will prevent us from failing.
But let me tell you the whole story. It is a story with a happy end. Thankful to this guy, Gerald Benjamin, who forced me to be a better dentist. He is photoshopped that a student of me, Monica Kecha, has done. She said I started a war to force dental technicians and prosthodontics from our clinic to do a better job. I got my DSD application and it makes my DSD planning so much easier. I am lecturing regularly for technicians and prosthodontics from our clinic. I am often in lab, and each dental technician had this wonderful drawing from Yanis Vergolis, XP member, on his or her desk. I take part in digital dentistry, and I got my VPI cervical system. It makes it possible to produce individual healing abutments in very little time and to deliver at the same time individual coping posts for prosthodontics, so almost nothing can go wrong. But let's go to the topic now, is the mIVAN approach to preservation surgery. mIVAN approach is a nice abbreviation of very complicated name. I have to learn it by heart for each lecture. It's interpositional vascularized augmentation neogenesis. But it's nothing other than simultaneous hard and soft tissue augmentation. It works for socket type 2, socket type 3, and for the ridges with horizontal atrophy. There are some beautiful techniques for surgical treatment of socket type 2 and socket type 3. On the first place for me, for immediate dental-alveolar restoration from Dr. Da Rosa. His lectures are available on Dental XP. I love tuberosity. I modified his technique utilizing a graft, tuberosity graft that contains cortical bone and trabecular bone. And I used to also densify this bone graft, and at the end, on the buccal, I have a structure like a socket shield. It works really nice, and I have nice results with this technique. Professor Denis Tarnov, we are all familiar with his ice cone-shaped membrane for staged approach for socket type 2. And the same guy that said One Miracle in Time published in 2015 an article about immediate implant placement into socket type 2. And a very similar approach has also Konstantinos Valavanis. His lecture is also available on Dental XP. And not to forget Professor Buza and his team with early implant placement, and now he has 10 years result already. The change is the only constant, and I love to probe new techniques, new materials. But otherwise, don't change the winning horse. And each time when I see socket type 2, I think I'm going to try another technique. I'm going to place immediately an implant. But then I see my patients. Most of them are very young patients, and socket type 2 is consequence of a childhood trauma. And then I go back to mIVAN technique because I know it works predictable in my hands. I feel at home with mIVAN technique. I submitted an article for publication with 25 mIVAN cases with follow-up 1 to 11 years. How I came to mIVAN technique? Well, if the buccal bone wall is missing, we need to do hard tissue augmentation, and we have to do some wound closure. It was the only one time that I have done coronally advanced flap. I don't like it because mucogingival junction is displayed. Often we see scars. There is a risk of papilla shrinkage and also of keratinized gingiva reduction or loss of keratinized gingiva. I've done some cases with early implant placement with GBR and no connective tissue graft. And in my experience, if biotype is not really thick, I don't get nice gingiva texture and color. I don't talk about recession, marginal gingiva level. I talk about gingiva appearance. It's always shiny and somehow bluish. And what I miss here is a connective tissue underneath mucosa. It gives that nice gingiva stippling. And it was logical to me to utilize pediculated connective tissue graft. With pediculated connective tissue graft, thanks to the blood supply from the palatal blood vessels, we can cover socket opening, and by introducing of connective tissue graft into the vestibular tunnel, we additionally build a soft tissue volume. It's nothing new. It's introduced in dentistry in 2003 by Sklar, and many other authors have described surgical procedures with utilization of pediculated connective tissue graft. As I wanted to publish one of my mIVAN cases, I've done literature research, and then I have found out that it's already described. It's described by Fagan and his team in 2008, and he gave this name interpositional vascularized augmentation neogenesis. As I already said, it's nothing other than simultaneous augmentation of hard and soft tissues. The difference in my soft tissue management is that I don't use pediculated connective tissue graft just to cover the socket, but the tunnel in vestibular soft tissue is done, and pediculated connective tissue graft is introduced into this tunnel. This way, this graft get additional blood supply, and as Professor Khoury said, every blood vessel is welcome, and we have connective tissue graft to give a nice additional gingiva volume and nice gingiva color and texture. And again, I'm not the only one. I recently experienced that Michael Pico's video about pediculated connective tissue graft is the video with the most views on Vumedi. My modification of hard tissue augmentation is that I use to fill the socket with autogenous bone. This way, implant is going to be surrounded with autogenous vital bone. And to compensate for socket remodeling, to slow down autogenous bone resorption, there is a layer of slow resorbable bone substitution material on the buccal. And membrane is Dennis Tarnov's famous ice-cone-shaped membrane. And this is how it looks like in CBCT. Let's see animation. The first step is preparing of vestibular tunnel. Single incision technique for connective tissue graft harvesting. I prepare sutures in order to avoid later manipulations. Layered hard tissue augmentation and connective tissue introduced into the buccal tunnel. Let's see some cases. A young patient, buccal bone wall is missing, hard tissue augmentation, ice-cone-shaped membrane, a layer of slow resorbable bone substitution material placed on the buccal, and the socket itself is filled with autogenous bone. The autogenous bone is harvested from palate, from the same place where connective tissue graft is harvested, and this way an additional donor site with donor site morbidity is avoided. Here some insights from healing, flapless implant placement, prosthodontic treatment finished, and the result after 4 years. In another case, look at these long papillas. There is a fistula, central incisor has a vertical fracture, and the left lateral incisor has a periapical area. We decided to redo endodontic treatment for the lateral incisor, but the central incisor was hopeless. mIVAN technique was performed together with cystectomy and apicoectomy for the left lateral incisor. Here is the healing. Please pay attention that on the coronal part of the socket there is only autogenous bone. This way the coronal part of the implant shoulder is going to be surrounded by a vital bone. Patient with provisional, 1 year after implant prosthetic rehabilitation, and now we already have 6-year follow-up. mIVAN technique works for socket type 1 but also for socket type 2 if the buccal soft tissue is reduced or damaged. A young patient who came 4 days after multiple root fracture, he got it during New Year Eve, and he had a fight about a girlfriend and came to our clinic on January the 4th. It was the first day after Christmas and New Year holidays, and the waiting room was like that. I decided to go for mIVAN technique. I was so in hurry that I managed to place only two sutures on the palatal, the healing, and the final result. This is one of mIVAN cases with the longest documentation. It's done 11 years ago. The patient with socket type 2, she was in pain. She has taken antibiotics for days and weeks, and she wanted the tooth out and later on implant placement. I didn't dare to put any augmentation material into this socket, so I have done what I have learned from my mentor Bob Lamb. I have done what I would call prosthodontic socket preservation. A Maryland bridge with a pontic for soft tissue support was prepared before the tooth is taken out. And here we see that ridge atrophy is really reduced. There is some loss of the horizontal ridge volume, but it's really reduced. Already 11 or 12 years ago, guided surgery for implant placement, mIVAN technique with simultaneous hard and soft tissue augmentation, patient with provisional, it was in 2006, and here some pics from 2006, 2012, and recently I got follow-up from 2006. And the x-rays doesn't look the same, but it is the same patient. She is a friend of a dentist in Munich, and she got, I think, 4 or 5 crowns on this implant in time. I'm not the only one in which whose hands mIVAN technique works predictable. I posted my mIVAN cases on Dental XP forum, and Bogdan Akatrine has done his cases, and he was kind enough to send me his mIVAN treatment with a really nice preliminary result. All my students are performing mIVAN technique. His case of Matko Ogoic, and I have chosen this case to show you that we are developing mIVAN technique further. Our new favorite bone augmentation material is dentin graft, autograft, and the most of these teeth are not candidates for autograft material because they are root canal endodontic treated teeth, but often we find wisdom tooth that can be utilized for autograft. And here you see some inserts. Wisdom tooth is crashed and we have dentin graft, and instead of a collagen membrane, just PRF membrane, and beautiful result, beautiful gain of the rich volume. Like with all other therapies, there are complications. It's very important to avoid pressure from the pontic on pediculated connective tissue graft. But here we see advantage of the buccal tunnel because there is additional blood supply, and despite of graft strangulation, both parts of connective tissue graft survived. This is a situation 6 years after mIVAN technique was done for this patient. Sometimes I see, seldom, but sometimes partial, superficial graft necrosis. This is a colleague from my clinic, and it's easy to handle, just to cut out this superficial necrosis. And this is situation 3 years after the treatment was finished. This patient has done everything to destroy my work. He was diving, putting this mouth appliance and breathing through it, and he put every cream and oil that he could find onto this connective tissue graft, but at the same time he didn't dare to clean adjacent teeth. It was graft necrosis. Let me go back to see again that the buccal part of the connective tissue graft survived thanks to the blood supply from buccal soft tissue. And here we see that it's not a great makeover case, but we can see that we didn't lose tissue, we gained tissue. I don't feel like finishing my presentation with complications. I want to share with you my favorite combination, and this is combination of mIVAN technique and the partial extraction therapy. This is initial situation. The buccal bone wall, not only buccal bone wall, for the left central incisor is missing, the tooth is ankylosed. Look at this bone and the soft tissue level. But good news is that the bone between two teeth is well maintained. So I decided to go for mIVAN technique for the central incisor and partial extraction therapy for the lateral incisor. And this partial extraction therapy, C-shaped socket shield, was so important to get and to keep inter-implant papilla, inter-implant bone. mIVAN technique for the left central incisor. At the time of implant placement, additional rich augmentation utilizing autograft. We used the wisdom tooth, LPRF membranes, and here's the result. It's not ideal, but it's nice. It was mIVAN technique and partial extraction therapy side by side. And let's see it all together for one side, for this central incisor with a recession. This is what we want to have. partial extraction therapy with socket shields for lateral incisors, for implants, and Pontic shield for this central incisor with recession. If we have Pontic shield, we don't need any other hard tissue augmentation material. mIVAN technique with pediculated connective tissue graft, and here is patient with a provisional, and here is the patient with final prosthodontic treatment. And this case was introduction to the great discussion on tooth replacement. My heart was with Howie and Maurice and partial extraction therapy. Let me finish with a picture from my Orlando group, and thank you for your attention.